very good afternoon, lunchtime, but uh, we have some interesting talks lined up, trying to choose between the correct refractive procedure. We all understand that we now have many good procedures available to us, unlike 20 years back when we started with PRKs and went to LASIK and then came back to the surface, and then now we have like lenticules have taken a lot of interest. We have topo-guided LASIK, like the Contura kind of procedures. We still have a lot of developments with PRK. And yes, phakic lenses have also now become very, very popular. And today's course will try to tell us that when and how to use each of these procedures and how to use them rightly. We have a stellar faculty with us, Dr. Kumar Doctor from Bombay, Dr. Mahipal Sachdev, Dr. Pooja Kamar, Dr. Chitra Ramamurthy, and Dr. Shivani Patnaik. And they will be covering, this is the scope of the course. So we will be having myself, I'm Gaurav Luthra, and have about 20 years of experience with laser correction and ICLs as well. So this is how we'll go. So there's a little bit of change in topics and speakers because of clashing sessions, but we will be covering the extra procedures and as well as femto and microkeratome LASIK, whether they still have any takers. PRK, PRK extra and Smile extra as well as phakic lenses. So going on, I think we have seen how refractive surgery has been evolving over the years, and it's been an amazing journey. And in fact, 2000 onwards, there has been so much development. Till 2000 was a very slow process, and today we have so many options when a patient comes to you, and we have to be careful not to push one procedure to all our patients, because each patient might deserve one of these procedures and should be given a choice, and the surgeon should be able to decide what might be best for a given patient, rather than selling one particular procedure over everything else to every patient. FDA approvals came in starting about 25-30 years back. PRK, from you can see a big range of approval from -12 to +6, with up to 6 diopters of astigmatism. LASIK, again, similar approvals. Smile was approved only up till -8 for sphere initially, and total of 10 diopters of spherical equivalent, including astigmatism, and up to 3 diopters of astigmatism for myopia. Hyperopia approvals are still in the process for many years, and I'll invite Dr. Shivani up to the dais. Phakic lenses have become very popular. They took time for getting FDA approvals, but we were using them again for almost last 18 odd years in India, and much before that in Europe. The one current generation one, and of course before that we had the Veriflex and the Verisize, and our own Indian version of the Iris Claw lens. Dr. Daljit Singh was using it almost 30 to 40 years back as a phakic lens as well. And of late, with advances in cataract surgery, RLE or refractive lens exchange has picked up a little bit as well, and it remains controversial, but if we do the right case selection, again it's a very good tool. So these are some of the procedures. Now when I write Smile, this slide is probably more than a year back, when there was only one lenticule procedure. Now we have several. There is Atos, there is Elita, and they've all taken a lot of interest. Almost all manufacturers have got into the Kalex technique or the lenticule removal procedures, and they are gaining ground because of a lot of advantages. In my practice, almost 70% is now lenticule extraction. Contura LASIK, again, a remarkable tool. I mean, Contura is just one brand, but topo-guided LASIK for virgin eyes became very popular over the last 7-8 years, and caught the fancy of a lot of patients with a lot of aggressive marketing. So a lot of patients come and ask for Contura when many of us may not have it, but one has to be able to know whether when to use it and when not. You can't be using Contura for every patient. And then of course the other procedures. So selecting the right procedure could depend on several things: availability of equipments in your practice, or how you might want to use somebody else's equipments for your surgery. Surgeon would have their own preferences. So some surgeons might want to, in their hands something might work better. They may have more confidence on a procedure, and they might want to do that more often than others. Sometimes it's the patient who wants a particular procedure, and they will come and ask you that this is what I want. And sometimes even if they are qualifying more for something else, you might end up doing something that they are very keen for if it doesn't work against them. And then of course the most important thing is the patient parameters and indications. So a good thorough evaluation of the patient, a good chair time with the patient, trying to understand why they are looking for refractive surgery, would also become very, very important in this decision making. And as I already said, you could have self-owned equipment, shared facilities, an existing facility, eximers, microkeratomes are going away, but it's still around in many centers. Femtosecond lasers and the lenticle extraction and phakic lenses. So I think with this I would like to move on and come to what I'm speaking for today, because the first speaker is stuck in another session and has requested me to speak instead as the first speaker. So there is this Contura LASIK which is popular and has been in India, has taken a lot of popularity over the last 5-7 years with aggressive social media marketing. And as we all understand, contour is an outline representing the shape or form of something. So contura is basically a topography guided reshaping of the corneal surface, along with that correcting the refractive error. So it goes beyond just correcting the refractive error and trying to give you a better corneal shape to give you better quality of vision. So femto-LASIK treatment options could be wavefront optimized, and which doesn't treat any of the pre-existing higher order aberrations, and that's the standard LASIK procedure which almost all machines offer today. We were doing wavefront guided treatments a lot in the past. It was very popular with that abrometer assisted customized wavefront guided treatment somewhere in the 2000s. Before 2010 they really caught the fancy, but as all of us realized that they were not really doing a great job in giving patients any major benefits, and they were unpredictable as well, because they depended on the pupil size. Aberrations change as the pupil size changes, and also lenticular aberrations, if you're trying to correct on the cornea, does not make sense. It does not work that well. We also did a lot of Q value based treatment, especially for presbyopia. You could customize the Q value for better quality of vision, depth of focus, and they were also being used for giving micro monovision by adjusting, making the cornea more prolate, and the FCAT treatments on the wavelight laser, but by different names on other lasers. You can customize them. And then of course topography guided is not new. It's been around on the Zeiss platform and on the wavelight platform for 15-20 years, and we were doing again topography guided even before Contura was born. So how was Contura born? That's a brand which came up when Alcon decided to launch this for virgin eyes. So essentially why Contura came up was that the US FDA insisted on Alcon first proving that it is safe in virgin eyes before being offered to patients who required topography guided treatment. So a trial was done where they essentially did topo guided treatments on virgin corneas which did not have any significant aberrations, to do a superiority trial whether it was equivalent or better. And what they found was that when they combined topography guided treatments with the surface with the optimized treatment, they found that the results were much better. So that's where Contura was born, and was introduced to the market about 7-8 years back. It utilizes the topographer, which is the wavelight topolyzer Vario, which will give you send the data to a treatment planning system, and that will further send it to the machine, and then you can just check all the parameters, and we'll come to that a little bit. So it's a topography guided treatment for virgin corneas, and we've already heard about how FDA did this for Contura, and it treats pre-existing higher order aberrations on the cornea by doing topography maps. It prevents induction of new higher order aberrations as well, and it's based on corneal wavefront, and so it's not influenced by the internal wavefront of the lens or other things inside the eye. It's also independent of pupil size and accommodation, and it is centered on the corneal vertex rather than the pupil center. Most lasers will fire, the trackers will be basically firing on the center of the pupil, not on the visual axis, whereas these treatments are centered on the corneal vertex, so more likely to be very close to the visual axis of the patient. And how Contura is different from wavefront optimized is that wavefront optimized only treats the refractive error of the patient using the keratometry readings to customize it for each patient, whereas Contura would also goes beyond that by correcting the aberrations on the cornea, ending up with better results for the quality of vision of the patient. And of course, we already discussed that wavefront guided was not the best way to go, because 70% of the aberrations are basically from the cornea and not from the inside of the eye for young patients. And wavefront guided basically considers higher order aberrations of the whole eye, including the lens, whereas we are treating on the corneal plane, so it is actually counterintuitive and that is why now topography guided is more popular than the wavefront guided, which has lesser indications today. So when Contura was launched, actually Alcon came up with some nomograms, and there were strategies, because in 2017 they advised that surgeons should calculate treatments based on the patient's manifest refraction, and also they were, the patients were not getting great visual acuity results as they would want, and an effort was then made to treat completely off the measured anterior corneal astigmatism. So the TMR system, or the topography modified refraction, was developed by John Canelopoulos to begin with. And however, there were cases in which treating the full topography guided manifest refraction led to the axis being flipped. So, there will be times when your manifest refraction is at one axis, say at 180, whereas the topography guided is trying to treat at 150 or 120. So if it is off by more than 10 or 20 degrees, you'll end up with a very, very significant poor result. So seeing that, some of the surgeons began to treat only 50% of the difference between the manifest refraction and the measured astigmatism. Measured basically is from the topography. So ideal candidates for Contura, it says 18 and older because that's what the FDA trial said. But I personally would prefer to see refractive stability beyond 18 years of age till about 21 today. And we don't like to operate even right till 25 if refractive stability is not achieved. There is no urgency to do refractive surgery. Virgin corneas, and then you have the approvals, as you said, for myopia and astigmatism, up to 3 diopters of astigmatism and -8 to begin with. And today you can do much more. And good maps. Now that is the key. If you are going to do a Contura treatment, you have to have topography guided. You have to have very good captures of the data on the cornea. So what you would not want to do is enhancements, poor quality maps, stromal scars, PTKs, lenticular changes, and cataracts. So if you have a lot of corneal aberrations other than the ordinary, which means non-virgin eyes, it might be a good idea to just do a topo-guided treatment rather than a Contura. So step 1, as we already discussed, is topography, which should be reliable, and they take 6 scans, which should be reliable scans. You should not include scans which are not of good quality. I'll show you what would be a good quality scan. And this is a good scan because you can see that it is covering up much of the cornea over here, except some of the superior where the lashes and the lid is. Now this would not be a great scan. You can see there are a lot of areas of dropouts. Even in this area the scan is not good. So these scans may not be good for treatment and should be excluded. And of course poor topography scans will also be marked out by the laser itself, telling you that the quality of the scan is not good for a 6.5 zone, only good enough for a 5.5 zone, as is here. So once you have these scans available, then you can select the ones which you want to include in the treatment, because then the machine will average out these scans and create a treatment plan. So once the planning is on to the planning stage, we get a set of values, and it says that the measured, that's basically from the cornea's topography, what we are measuring as the sphere and the cylinder and the axis. So this is how it looks. You can have these 6 scans, it's averaging out them, and then it is giving you a median, case and the measured treatment. So this is what the, this is the subjective refraction of the patient. And then once you've fed this and gone to the Contura topo, planning, then you will get the measured, which is the second row. So for example, your refraction is -6.75 with 1 at 20, but the measured is spherical, of course, does not matter from the corneal measurements, but it's measuring a 1.6 astigmatism at 12. And then you have to decide in the bottom row what you want to feed as the final treatment plan. Now, how do we do that? We first put 0 into the treatment plan, and as soon as you put 0, it basically removes all the refractive error from the treatment plan and gives you only the aberrations. So once you know what are the aberrations, then you can do the planning. So let's not go into details of the planning, because that's beyond the scope of today's talk. But once you have these measurements and you compare it to the manifest refraction, you can decide if they are matching up. If the astigmatism cylinder is matching up with what you got on topography, things become very easy, because then you just go ahead with the treatment. It's much simpler. But when the astigmatism magnitude or the cylinder or the magnitude or the axis of astigmatism is not matching up with between the manifest refraction and the topography, then you have to decide what you would like to do. And here comes a very useful method at the bottom here. So there are several ways. As I said, option 1, you can treat the manifest with tight constraints. You can treat the measured cylinder and axis, making adjustments for the spherical equivalent. So what all we went through over the first few years of Contura, but what we eventually do today is the Forcides software, which helps us do the planning. This is a proprietary software which for Indians it comes free from the US by Dr. Mark Lobanov on request. So it's basically like a geographic imaging software for refractive surgery, It's a very useful software. You just basically, utilizes the concept of talus, which is basically the secondary elevations on the primary elevation of the cornea. And each of these aberrations would actually be inducing their own refractive errors, so you would want to treat them. So essentially you can see here that it is trying to treat the aberrations by doing, these are the taluses which you can see in purple. I'll finish within 2 minutes. And it utilizes measurements from the anterior corneal astigmatism, it utilizes the talus astigmatism, it also utilizes the posterior corneal astigmatism from the pentacam, and it utilizes the internal astigmatism as well from the refraction, and then comes up with a treatment plan. I'll just show you this case which will help easy understanding of how the Faucides works. A 22 years old male with very high astigmatism, and these are the patients which will really benefit for contour treatments because it is also correcting, it has cyclotorsion control, it does iris registration. So you will actually treat on the corneal vertex with cyclotorsion control. This patient had a -1 with -6 at 20, and the other eye -1 with 5.25 at 155. And the Ks were matching up with the much of the astigmatism. So basically patient with high astigmatism but symmetric bow ties and a fairly good pachymetry. The Bellin maps was also normal. These are the scans, and you can see that they are quite fairly good symmetric maps in both eyes, and the eye trace showing up also that the maps are fairly consistent. The aberrations are, internal aberrations are very few, mostly on the cornea, high astigmatism for this eye as well as the other eye. So this gives you the comfort that you are on the right track doing a contour treatment. Epithelium maps and anterior maps also good enough. So what should you do? You could do a toric ICL for high astigmatism, or you could do a contour LASIK over here. So we went ahead with the planning on the Faucides, which, as I told you, takes data from the pentacam, from your refraction and from the topolizer, and comes up with a treatment plan at the bottom here. So it is suggesting we treat 1.2 sphere with 5.5. This is the manifest, 0.75 sphere with 6 at 20. It has suggested that we do a 1.2 sphere. It's cut down the cylindrical treatment to 5.5 at 19. So this is a very kind of no nonsense kind of a thing which helps you make these treatment plans. We went ahead with the treatment, and this is the post-op cornea's shape, which comes out pretty good. Patient got an excellent result for both eyes and was almost 6 parts on day 1 with very good astigmatic corrections. So these are very gratifying results. We've been using Contura and Faucides for almost 7 years now, and for select cases where there are high corneal aberrations. So I'll skip this case number 2. It has transformed Contura treatments.
Gaurav, you have time.
I'm done.
Other speakers are taking time.
I had 2 talks, so I'm just putting.
No, you have time. I'm saying you have time. Other speakers are getting late.
Shivani is here already.
No, Shivani doesn't have a presentation. She's going to get it.
Oh my God. Okay. We'll have a small discussion. So when to choose Contura over Smile? I also like to, while hyperopia does not work with Faucides, but if you want to treat on the corneal vertex, now hyperopia as well requires, we end up having angle kappa, which compromises hyperopia treatment. So when you're doing a topography guided treatment, in fact, John Canelopoulos did a lot of work on topo guided treatments for hyperopia, and it tends to treat on the visual axis or the corneal vertex rather than on the pupil center. So when you must have realized that all of us who do refractive surgery, we end up decentering our hyperopes because of the significant angle kappa. That is no longer required when you're doing a topography guided treatment. So hyperopia will do well if you're trying to do a topography guided treatment. Any thoughts on that, Kamal? On your machine, what do you do?
Same thing, visual axis.
So yeah, visual axis, right? So also high astigmatism, as you saw, our results for high astigmatism improved drastically with using the topo guided part, because basically what the topo guided is doing, that it's also checking for the corneal astigmatism and the manifest, and then trying to get the best outcome, trying to combine both of them and seeing whether it works well. Also, when you have very high corneal aberrations and coma, etc., you will have better results with topo guided treatments. And if the patient wants it. Now, this is something which is a new thing for us. Social media and a lot of Googling has given patients that knowledge that they think that they know better than the surgeon who's actually going to perform the surgery, and they go shopping, and then they eventually come and say, okay, I want to do this. And sometimes it becomes very difficult. You have a patient who has predominantly sphere, almost no astigmatism, hardly any corneal aberrations. I would obviously offer that patient a Smile, something like a -5 or a 6 sphere patient. They come and ask that they want Contura. You try to explain to them that, unnecessarily I'm going to cut a flap on your cornea, weaken it, and you're not going to gain from a Contura treatment in any way. And Smile would be an ideal treatment, but patients sometimes feel that the doctor has some personal interest, so it becomes very difficult, and sometimes you have to eventually say, okay, if you are so keen to do it, as long as it's not hurting you, you can still go ahead with the treatment. And so to finish, I think newer excimer technology is helping set new benchmarks. There's lots of procedures available today. We have a lot of choice, and we should try to offer the choice to the patient. And if we don't have a procedure which the patient really needs, we should not hesitate to either go elsewhere and operate or refer them for that procedure to someone else. It's not a great idea to keep offering what you want, what you would have or what you would like to do, and may not be to the full benefit of the patient. And Contura offers a new option to already excellent results that we were getting with wavefront optimized treatments, and the 4 cities planning software has made a lot of help for us in the Contura treatment plannings. So with that, I'll stop, and I'll request Dr. Shivani who's agreed to speak instead of Dr. Sri Ganesh, who's had a surgery for his shoulder and could not come to AIOS.
I think, Gaurav, by the time Shivani loads it, some interesting observations. Have you ever had a patient, Gaurav,
Yeah.
where you corrected most of the high order aberrations, but the patient is not very happy with it? Because there are some reported cases, because some patients are habituated to some of the HOAs. And I remember you and me were together at Rohit's conference once, and he shows how beautifully the human crystalline lens has adapted to those aberrations. And once you unmask the aberrations on the cornea or remove them, so the compensatory mechanism of the crystalline lens keeps standing there for a couple of months. And during these times, the patient may have issues, and contrary to what we were thinking, how the patient will have the wow effect, which was not there. So have you ever had a patient like that, Gaurav?
Yes. So there will be times when, if you do an eye trace, you will find that the internal aberrations and the corneal aberrations may either be kind of additive to each other, or they may be contrary to each other. So sometimes you'll have astigmatism on the cornea which is very high, and the opposite astigmatism on the lens, with the lenticular astigmatism is kind of in the opposite meridian. And if you try to do a topography guided treatment on the full corneal astigmatism, for example, there are times when your cornea has like 5 diopters of astigmatism, and the manifest is only 2.5.
Yeah.
So when you do the eye trace or the aberrometry and you try to segregate the corneal astigmatism from the overall astigmatism, you'll be able to take out the lenticular astigmatism. So some patients will have the lenticular astigmatism neutralizing almost half of the corneal astigmatism. Now here, if I go with a Contura treatment without the 4 cities engine, or I just go with what Alcon was originally asking you to do, is to treat the full topographic astigmatism, you will be in a soup, because you would have corrected 5 diopters of astigmatism on the cornea. Patient needed only a manifest of 2.5, and is going to have that lenticular astigmatism now inducing the opposite astigmatism, and you'll have a very dissatisfied patient. So that's why it's very important. Every patient is not a candidate for all kinds of surgeries, and you have to really decide which surgery would. I have a few cases like that. Towards the end of the course, I can show one of those cases.
So that's exactly what I wanted to bring out during this questionnaire, was that all the HOAs are not bad. And like on my machine, we have another analyzer, it's called the ORCAM, and you can actually, I use an eye trace for a similar situation also to segregate that how much of my lenticular issues are compensating for that. So if you take away everything on the cornea, the lenticular issues will stand out more. So these are the cases where it's a good idea, before you plan any heavy, high-handed approach on the high-order aberrations, to rule out the internal and the outer.
Kamal, if you did not have an eye trace, because many people in the audience who are practicing may not have an eye trace or an OPD scan to segregate the aberrations, and you had a patient, like, there would be obviously easier ways to, without having all the devices. For example, you had a patient come up with a very high astigmatism on cornea, but much less on the manifest. Would you treat the manifest refraction, or
then
would you
in that
try
situation, if you have nothing, then probably err more towards the manifest.
Manifest, that's what I wanted to say.
Never.
Then we would rather go towards the manifest than what was on the topographic or the corneal astigmatism.
And classically, at times you'll see, you may have cataract patients who got a LASIK done, and they were at that point 6.6 whenever they got it done. But when you do their keratometry, and that is the thing which to stimulate your mind. In the keratometry, they have astigmatism, but they don't have any manifest astigmatism. So which means the laser corrected something to correct the lenticular issues also at that particular time. And now once you're supposed to take out the lens, so the question is, my optometrist used to ask me, sir, the patient has a history of being 6.6 post-LASIK, and now we're treating astigmatism. So the common sense is, I'm taking the lens out. So whatever the lens was compensating is not going to be compensated, and now it's only the cornea which is going to manifest. So then you treat the corneal astigmatism.